Well, thank you very much for the invitation to come and join you today. Before I really do anything, one of the important things that I always feel in any sort of educational setting is to understand the audience. So if it's all right, could I have a show of hands? Who of you are specialists in liver disease here? Who of you only work in an academic setting? So quite a few academics. Are any of you GPs? Not one GP. How many of you write to GPs? So a few of you. How many of you talk to GPs? So quite a few of you. So I hope that what I'm going to be talking about, I'm a practicing GP in the UK. I do hope that what I'm going to describe today is understanding a different audience viewpoint on the whole sort of understanding of liver disease, and really to take away that sense of some audiences are not very interested, but they're still very important. So you don't have to be very interested in a condition in order to have quite an important role. So I'm hoping that we can, in a way, pull out some quite strong themes about how hepatologists and the field of hepatology can help the rather disinterested colleagues in primary care to do more, and to do more without necessarily realising that they're doing a lot more. So I've been involved in the Lancet Commission, both in the UK initially, but also the current European Commission on Liver Disease, and I was also a member of the NICE guidance in the UK on NAFLD. Why is that not working? There we are. So really what I want to talk about today is to understand how liver disease comes across to primary care, so that we've got that very different perspective on really our specialist topic today. How does that sit within a very competitive field? There are an awful lot of specialist topics out there, and GPs actually deal with the whole lot of them. So how can we help liver disease actually fight its corner a bit more specifically to that primary care audience? And also, really, we can have an awful lot of progress without necessarily GPs knowing anything at all about NASH. So we'll try and make some sense of that. At the moment, even though liver disease actually is relatively common, its perception is that, as I say, when we think about that sense of competition, it's really small fry when we think about the main burden of my workload, which is cardiovascular disease, but it's elderly care, it's women's health, it's giving contraception, it's management of hypertension. So the actual the actual delivery of care is much more about holistic actions as opposed to specific diseases. And I think that can sometimes help us understand how a disease might pitch, as I say, amongst a competing set. But also, most of my patients will have several conditions, and that's really where one of the opportunities lies, that my patient who has liver disease is very likely to see me for other conditions. So we've got a real opportunity there. And a lot of the conversations that relate to liver disease also relate to those other comorbidities. So how can we, in a way, pull together those conditions into one metabolic basket? So in terms of UK mortality, a few years ago, we do see that liver disease features for men, but it's only number 10, and it doesn't actually feature in the top 10 causes of death for women at all. So I think it's a little bit further down that list. So again, our perception is that we don't see liver disease. It's uncommon, same as I would generally consider that leukemia is pretty unusual. It's not far off a rare disease. So again, when we think about how this comes across in that competitive disease field, it is a relatively small component, but still very relevant. So I thought that as Jeff has already said, coding, in fact, both speakers have already mentioned about the importance of coding. So what I've got here is actually an audit from my own practice. This was an audit I ran back in 2016, and we'll look at the 2016 figures first. So we've got a list size of about 16,000 patients. And at that stage, when we looked at any liver disease coding, we've got less than 2% of our patients who got any coding at all. Of that number, only half of them had actually got an alcohol status recorded, and the majority were a coding of fatty liver, which isn't actually a diagnosis, it's only a clinical finding, usually from an ultrasound scan, and often an incidental finding. So the number that had actually had their clinical sign translated into a diagnosis by a clinical assessment was less than 0.01%, so for 4 of our patients, and we had no recordings of NASH at all, and cirrhosis occasionally was found, and over that year, the deaths that year, 2 out of 103 were liver disease related. So bearing in mind our appalling coding here, it's quite astonishing that we've actually then still got 2% of our deaths relating to liver disease. So that was an interesting finding. But since 2016, I was part of the, as I say, the UK Lancet Commission, and one of my proposals was for our Royal College of GPs to make liver disease a clinical priority. So we had a lot of different people working on that, raising the profile, lots of sort of increased awareness, different types of training things happening. We've got a toolkit on our sort of national website now. And so there's been lots more noise over the last few years. And certainly in my own practice, I've done some training there. So what impact has that had? Well, in fact, our list size has crept up a bit because we've actually absorbed a neighbouring practice. But we've actually improved our liver disease codings in general by about almost double. So our coding has improved. And our liver disease, our alcohol recording is definitely improved quite a lot, which is encouraging. We seem to be doing an awful lot of scanning for lots of reasons, partly because pathways for other conditions have changed. So, as I say, these, again, are largely incidental findings. And our prevalence of NAFLD has now reached the heady heights of 1%, so, which I think actually did fit with some of the other speakers so far. But we still don't have any recordings of NASH. We did actually, how do I go back to the, sorry. We did have some codings of steatosis of the liver, but to be quite honest, I'm not really sure whether that's just another word for fatty liver or whether or not that was something in a letter from a hepatologist. We're not really sure. So the coding isn't really even very accurate, I don't think. So we did actually have 18 cases of that, but I'm not really sure quite what that meant. Our cirrhosis recording, though, has pretty much doubled, and I was quite surprised at that whether or not that's better awareness or because we're referring more people because of the increased sort of attention to the liver. I'm not sure. I'm sure it's not going to reflect a true difference in prevalence over a 3-year period in a pretty stable population. So this is going to be a recording thing. And we are still seeing 4.6% of our deaths relating to liver disease. So despite that perception that we think liver disease is uncommon, well, it's actually featuring in the mortality rate. So again, we should be more aware of this. I was also very reassured to see that, again, recording of hepatitis B and C has picked up significantly. So again, raising the profile, we can see very short-term changes in actual practice on the ground. So some of that work has been effective, even though nobody's got a clue about NASH. So we don't need to know about NASH specifically in order to be able to drive up standards of care and improve engagement. So why is fatty liver important to GPs? Well, we know that, as I say, we've seen in our own practice, there are deaths happening. Excuse me. But I think more importantly, it's highly relevant to the conversations that we're having. So it really is one of the big five. If we change the way we think about liver disease as just the liver's expression of metabolic syndrome, then that's quite a different conversation for GPs. We're dealing with metabolic disease the whole time. So how can we, in a way, sweep liver disease into that sense of understanding about that sort of metabolic picture that we know is so profound on what we're doing. So if we think about a very simple sort of fibrosis pathway, we've got, this is in terms of what do I think GPs really could do with learning about. Well, we definitely know that there are sort of 3 different entry points into this sort of fatty liver deposition. This is definitely my business. This is definitely my business. Alcohol, I talk about this a lot, largely for the sort of psychosocial elements, but obviously clearly for clinically, for metabolic reason too. Hepatitis C, I don't remember seeing a case in my surgery. It's not an infection that is locally relevant to us, but obviously that could be very different in higher prevalence areas. So that may be relevant in more targeted areas. We've then got this sort of process, but I'm not so sure about how much my GP colleagues need to know about this. What we do want to know is that if you've got any of this lot up here, it matters because it may tip out the other end with serious disease, which again is going to be my work, it's going to be my business. So if we think about what does this actually mean for GPs, well, I need to do something here on the top line. So I'm really struggling with this pointer. I need to diagnose, and I need to assess fibrosis, and I need to code. So at this level, I really do have work to do. For this sort of transitional phase here, I've already done the referral if I've done this bit correctly. So I'm not going to worry about too much around here. But by the time we've got patients who've got a diagnosed condition, we really, again, have a specific job to do, again, which is effective coding, but it's also, I have a very specific job to ensure that effective follow-up, that referrals, that effective follow-up is in place. We may well find if we were to look through some of my patients that their diagnosis of cirrhosis was made 4 or 5 years ago, and they've not been seen since. So my annual review, because this is a metabolic condition, I'm going to bring them in on a register. I can make sure that this coordinated multidisciplinary approach to care can actually happen. But I can do that without really needing to get confused about some of the processes in the meantime, so much as they are clearly important to all of you in the room. To my audience of GPs, I think we can simplify the story and make sure that the action points, above all, are the clearest things that we train. So we want to make sure that we really raise the profile of the importance of vaccination. Aren't we lucky to have the option of vaccination rather than this message at the moment about vaccination sort of deniers and that? We definitely have a role in case finding, and we'll talk a bit about that. And we really need to have more pathways, and that's something that I think is something I think we'll talk about more over the course of this meeting. But GPs really don't want to have to make up their management pathways themselves. We just want to be told what to do, as I say, in order for us to be clear and specific. But coding is something that we really need to focus on and improve that. But we don't need to know much about NASH. So let's keep it simple. Let's teach GPs about why it's matter. So we need to mention about the incidence. We definitely need to improve the fibrosis risk stratifying, and we need to have algorithms and pathways in place for that to happen. And then, as I say, we need to broaden our understanding of that metabolic, that sort of metabolic component, that liver disease is one of many conditions. So if we're talking about causes, let's not get too bogged down with detail. Let's focus on those top 3, because, again, these are the main risk factors. These are the entry points into this consideration. But obviously, training will include a whole set of other factors. And in terms of incidence, once again, I find that statistics can do an awful lot of things, can't they? And what we don't want to do is to confuse or to over-alarm people. We want to have a sense that it is common and it's important, so that we don't need to become too confused about this sense of alarmism, but we want to translate this into proactive, supportive, motivational conversations for patients. And I think that's quite an important aspect of when we train GPs. What's the quality of those conversations? How do we generate motivational drive? One of the questions that the NICE guideline group were asked to think about is, should we be recommending screening? And the economic modelling certainly said no. And that's basically because we don't have an effective intervention if you've found, if you've done the case finding. But that doesn't mean to say that case finding itself shouldn't be done. Yes, we should be recognising our high-risk patients and considering that. But most of our patients obviously are going to present as incidental findings because of either because of an abnormal finding on a scan or because of investigation of raised abnormal liver blood tests. However, if we're just relying on abnormal liver blood tests as our indicator, then we know that lots of patients will have fatty liver change, but with normal liver blood tests. So it's not really an effective starting point. But we don't have enough data, again, to recommend screening at the moment. So in the UK, our NICE guidelines concluded that if you had a diagnosis of fatty liver, that the fibrosis assessment would involve the ELF test. And that's a blood test that in some areas you can refer for. So even though we've had very clear national guidelines, when we look at the availability of the ELF test, it is at the very best patchy, and largely it has not been taken up. So this recommendation, this guideline has not been very successful in changing practice in the UK. A few areas have developed proper pathways that reflect this, but in fact some of the pathways that have developed are not using the ELF test at all. So we've still got a lot of confusion amongst the people in the know, really. So if we think, well, how does that message translate down on the ground to GPs? You know, we've got a guideline that nobody's following. How does that come across? So I think it's important to understand about feasibility of guidelines when we're involved in planning them. Well, we have got alternative ways, and at the moment, one of the commonly done fibrosis tests is the NAFLD fibrosis score. And the reason for that is that if I've been to a talk that's covered lots of topics, I might remember, I've got to do something about fibrosis. Ah, well, that one, it says on the label says it's to do with NAFLD and fibrosis, and it's a score. Okay, I'm going to use that one. If I was taught about APRI or FIB4, I'm afraid I can't even Google that 3 days later when I've got home because I just can't remember what the hell that was all about. So if we just think about how we're going to pitch messages to that non-engaged audience, we probably want to make it as easy as we can. So again, local guidelines that are specific and that help people overcome those barriers are very useful. But at the moment, we've got a whole set of options there. I've no idea how to compare these different things. It's not for me to make that choice. I shouldn't be in the position of having to work out which of these tests might be better, because that's not my remit. That's not going to make any good use of my limited bit of time that I might apply to this topic. So again, thinking about the need for pathways is really paramount. But again, coming back to why it matters to me, and this metabolic picture, we know that NAFLD is a risk factor for type 2 diabetes, for high blood pressure, for chronic kidney disease, all of which I am dealing with the whole time. But I'm also, it's going to be helpful for me to be increasingly aware that if I've got a diabetic patient who's also got NAFLD, they're going to be at much higher risk again of those cardiovascular problems. So again, that focusing of my awareness, my case finding, is going to be very relevant. And we've already also had mention of statins. Well, why again is that particularly relevant to us in our specialist area? I dole out loads of statins. In fact, I probably don't dole out anywhere near enough. But what we've had is a message that somehow there's a concern about somebody who's got an inflamed liver and statins, that there's some problem about that. And what we've actually seen is that people with liver disease are having their statins stopped in primary care because they're just aware that there's some vague concern about it. And we need to undo that message, that unless there is very significant inflammation of the liver that's rapidly progressive, we really want to promote statins for people who've got fatty liver. So let's not stop them, let's actually encourage people to start them. So again, that's a very positive message that we can all help to convey. In terms of treatments, well, as I say, lifestyle advice is ubiquitous these days. For most conditions, it's something we try to support. But as anybody who's got teenagers here in the room will know, if we just tell people to do things that are perfectly sensible and reasonable, there's a very good chance we'll be told exactly where to stuff it. So we do need to understand more about the motivational components of giving lifestyle advice. And certainly in the past, particularly I know from some of my background work in obesity, we know that there's a lot of historical harm that has been done by health professionals when doling out well-meant lifestyle advice without any understanding of what that patient's own perspective is. So starting to improve our ability to give motivational advice is a really important part of any training to do with liver disease, in my view. A simple element of that is that fear tactics often have the opposite effect to what people might imagine. So fear is more likely to actually trigger denial and resistance than to necessarily make people feel really empowered. So motivational interviewing, the proper training for that will help people to be able to construct their conversations quite differently. But as I say, what we also want to do, which is something I'm increasingly aware of, is that patients are motivated by things that they can sense themselves. So if I was just to say to a patient, look, I'm really worried about your cholesterol level, I think you need to go and sort your diet out and get a bit fitter, my patient is not going to have any sense of what their cholesterol is today, or in 6 weeks' time, or in 3 months' time, unless I, the clinician, have done another test. So the cholesterol level itself isn't a particularly good motivational driver. It doesn't really add to that patient's own sense of progress. It's not something when they look in the fridge, they can sort of help to understand how things are going themselves. So what we know is that the direct gains that a patient may feel are things about how we feel, or it might be pain, or it might be whether or not we can, our constipation has improved, which is of no interest to a health commissioner, who is much more interested in numbers and figures, which are nothing that the patient can sense themselves. So on a population level, great, but on a personal level, so in a conversational level, we probably need to be talking a slightly different language. In fact, I think we've covered most of that. So I just wanted to, just before we finish, just to touch on a few examples about where different organisations have addressed barriers. So we've got the example up in Scotland where, as this was already mentioned, there's a really very strong relationship with alcohol up in Glasgow, to the point that by the early 2000s, things were really getting out of hand, and international reputations were really looking very embarrassing. And so the policy overall, so Scotland developed a health policy which was to change the nation's relationship with alcohol, and they've obviously done lots to do with raising awareness. We've only just got the minimum unit pricing approved after many a legal battle. But the relationship itself, the work on the population, on the public, was happening all the time around that. And there's been dramatic changes since then. So taking a population level, but thinking about the personal messages that surround that is very helpful. But a complete bugbear of mine, when I have started using the NAFLD fibrosis score, because that's the one I can remember, tells me what, on the title what it is, and we don't have a pathway in my area, and we don't have access to the ELF test, is the bloody scoring system. Has anybody ever tried when you're in a real hurry and you're looking at another 30-odd results in your same, you know, whilst you're eating your sandwich at lunchtime and trying to get your results done, to actually interpret a minus number to 3 decimal points? Well, to be honest, you know, that's just in the too hard box. I'm just not going to go there if I can help it. And so I was, and this is a comment from a colleague, any scoring system that's complicated, I'd just rather not, thank you very much. I've just got too many other things to do. And also the chance of misinterpretation is very high. So I had a chat to a friendly neighbourhood mathematician as to whether or not we could just rescale it. And so I chatted to my son, who's a mathematician at Cambridge, and he said, "Oh, give me 10 minutes," and here he was. So he produced a completely rescaled version of the NAFLD fibrosis score. And what's more, he said, "Why don't you just traffic light it?" Because the action points for the 3 different groups are exactly the same, you know, are completely the same. It's not a graded approach. So we've got either reassure and carry on with the lifestyle advice, or we've got an indeterminate result, need more information, I'm going to refer you, or we've already got a sort of diagnostic idea here, I'm going to refer you. So just rescaling, and what's more, we could rescale all of the algorithms to produce that same traffic light approach, would be a very simple way to help GPs think, do you know, that's easy. Liver disease, that's a doddle as a traffic light. In fact, my lab can do this for me. They can actually send me the result in a colour-coded fashion already. So we've got mechanisms whereby the translation of the ask into primary care could be made a lot simpler. And then one last example of, as I say, putting addressing barriers, putting things into practice is the Scarred Liver Project, which some of you may well already have been aware of, which is a project in Nottingham they've reported, which is basically putting an algorithm into place. And their algorithm was actually based on risk on people with comorbidities in primary care, such as cardiovascular disease and diabetes, so the higher risk groups. And there have been lots of quite interesting bits of information about how practical this has been, what were the particular challenges to get a whole health district to adopt a pathway. And there are problems with capacity. So initially, the scans were happening quickly and the GPs were delighted, and now they've already accrued at least a 6-month waiting list for the scanning. But if we're talking about a long-term condition, that transition to cirrhosis being 7 or 10 years, then perhaps waiting 6 months for a scan isn't the end of the world. But there are issues around that. But of interest, what the GPs have already reported is that they are finding that the discussion about liver disease is a new and different way into the lifestyle conversations, and that they seem to be they seem to be welcomed and they seem to be productive. So I think, as I say, we've got good examples that things can change. We've got lots of examples that definitely there is improvements to be had, but actually they're feasible if we think hard about it. So GPs are not really disinterested in liver disease, but they're certainly not very confident about it, and we want very specific guidelines. We want to encourage GPs to do the bits that is their business, so raising awareness and doing the lifestyle stuff and referring for fibrosis and coding. And then from our point of view, can we simplify the ask for our GPs? Why don't we look at some of these mechanisms to give simpler information to our GP colleagues? So thank you very much.